Hello, my name is John Clapp. I have conducted thousands of emergency medical training courses all over the world. Today's video is about some of those medical emergencies that you may have in your office and some of the equipment that you need to help you. But the first thing you need to ask is, are you ready? It's Monday morning and you're seeing your 10th patient and your first medical emergency happens out in the lobby. You have to ask yourself, what just happened? Is this somebody in cardiac arrest, or is this a simple diabetic emergency where you can just use sugar and not call 911? If you do need to call 911 or your emergency medical service system, what is that specific number, and does the person calling know that number? And do they have the address so that when they call 911 they know exactly where to bring us in? Sometimes we pull up in the fire truck and there's a team meeting with us. They're telling us how to get to the office and which entrance or exit to go in and out of. Sometimes, depending on the size of the patient or the location of the door adjacent to the fire truck, will help us out if we have a specific door to go in and out. How about CPR? That cardiac arrest always happens when you don't have a CPR mask with you or a bag valve mask. Can you do hands-only CPR? In just a moment, I'm going to tell you, but it depends on how that person went into cardiac arrest. How about the AED, the automated external defibrillator? We know the survival rate from AEDs go up to 78.5% from 3% with just CPR. Some states require you to have AEDs. So should you have one in your office, or if you don't have one in your office, is there somebody that's close by that has that AED? Also, can you do ACLS with an AED? The answer is yes. Some clinics choose not to have big monitors and defibrillators and pacemakers and cardioverters, but rather they just want to have an AED in the office. They may have an ALS kit with some medications, and the answer is you can do the basic ACLS steps with just a simple AED. Let's talk about CPR. So cardiopulmonary resuscitation really depends on how this person went into cardiac arrest. If we had a patient in the lobby that had a sudden cardiac event, we would assume that their pulse ox is upwards around 96%, and hands-only CPR would move oxygenated blood and thus be very effective for the patient. But let's talk about that patient that was choking prior to going into cardiac arrest. Now their pulse ox is so low, chest compressions moving deoxygenated blood would have little to no effect whatsoever. How about the bag valve mask? Some offices have a BVM in the back. Maybe it's by the oxygen bottle. Maybe it's sitting in a bag in the back room there. Can you use that bag valve mask with or without oxygen? The answer is absolutely. You can use a BVM without oxygen. If that patient's in cardiac arrest out in the lobby or in the elevator, you can take a BVM with you and provide 21% oxygen, which is going to be better than using a pocket mask that has maybe 15 or 16% oxygen. Some of the oxygen bottles I've seen have what's called power inflators when you're doing CPR. Be careful about those power inflators. A lot of EMS systems have stopped using them just because you can over-pressurize the patient's chest and have barrel trauma problems with that. So do you need oxygen along with your BVMs? So giving oxygen is always a good idea, especially if somebody has chest pain. Sometimes some of the non-rebreathers and simple masks and nasal cannulas don't attach to the oxygen that's supplied in the office. Sometimes you need a separate bottle with what's called a Christmas tree on there so that you can attach some of your oxygen devices. We call it a Christmas tree because it's green, and we can attach the simple mask, the non-rebreather, and the nasal cannulas, as you can see right here. So do you need a pediatric bag valve mask? The benefit of a pediatric bag valve mask is it has a smaller volume, and the likelihood of causing barrel trauma is very minimal. In fact, pediatric BVMs have something special on them called a pop-off valve. It will actually relieve pressure at around 40 centimeters of water pressure. But it is possible to use an adult BVM on a pediatric patient because the masks on both the adult and the pediatric BVMs are universal. So if you only have an adult BVM, get a pediatric mask, and in that way you can use that bag valve mask with your pediatric emergencies. The difference is you have to limit the volume that you're supplying to that pediatric patient. How about the first aid kits? Title 22, OSHA, all the local, state, and federal guidelines. We put a couple of kits together that you can get on my website that will give you all the equipment that you need, and we've gone above and beyond what is actually required. Some of the first aid kits, of course, will have gloves, bandages, cravats, flashlights, Quick Clot. Quick Clot is an interesting product because you have to know how to use it. There's Cheeto Gauze, Hemcon, Quick Clot, all these different products. You have to know exactly how to use them and when to use them. Typically, Quick Clot was used for gunshot wounds or knife wounds, puncture wounds, things where there's a venous bleeding where we can fill the hole in with either gauze pad or powder or pellets, depending on the brand. And then do you need to put pressure on there? A lot of these Quick Clots, you have to put about 3 minutes of pressure after you apply them to make sure that the chemical is going to leach into the body and actually work. How about barrier devices like CPR masks? So some first aid kits have simple plastic sheets that go over the face. We recommend a barrier device that has a one-way valve and a 1.4 micron filter. Plus a soft mask like you see over to your left there. That soft mask will go on adults, children, and pediatric patients. It's very soft. It'll cover the mouth and the nose and all size patients. Also gives you that one-way valve and that 1.4 micron filter that's going to create that safety barrier between you and the patient. And finally, tourniquets. A lot of first aid manuals will tell you to place the tourniquet 2 to 3 inches proximal from the bleed and between the bleed and the heart. We disagree with that. We actually feel like the tourniquet should go high and tight and leave room for one more tourniquet. This is one of my favorite tourniquets. This is called the Cat 7. I use this in the military and also when I work for the Department of State. The Cat 7 is the combat application tourniquet. It's about $25. We sell it on our website along with our first aid kits. We've added this tourniquet to the first aid kits because we feel like it's one of the better tourniquets and you deserve the best products for your money. This is called the Soft T, the Special Operations Forces, and that's also a good tourniquet as well. Has a metal windlass. It's a little bit harder to use. The other one down here on the lower left-hand side of your screen there, that is called the SWAT, the Stretch, Wrap, and Tuck. One of the benefits I found about the SWAT is it works on pediatric patients. When I have a small child that has a bleed and I'm trying to apply a CAT, a combat application tourniquet, the tourniquet's actually too big and doesn't mold around the child's arm or leg. So I found the SWAT, the Stretch, Wrap, and Tuck, actually works really well for this. And then finally there's some quicker ones too. This one's called the RAT, the Rapid Application Tourniquet. So some of them are a little bit quicker, but again, I find that the Cat 7 is probably the best bang for the buck. Here's some AEDs. So as I mentioned, the automated external defibrillator. We know from studies that simple chest compressions, cardiopulmonary resuscitation, has about a survival rate of about 3%. With an AED, within 3 to 5 minutes, the survival rate goes from 3% to 78.5%. We feel like having an AED in the office is not just a luxury, it's downright mandatory. It saves a lot of lives. And another thing you can do with an AED is help diagnose the patient as to whether they're in an arrhythmia or not, or asystole or PEA, and then you can do your ACLS as well. We sell the Zoll AED on our website. There's all kinds of AEDs out there, and they're all good. We just feel like the Zoll AED, again, gives you the best bang for the buck. So as you can see, I have one AED here, and when you purchase first aid kits from our website, you can purchase them with or without the AEDs. Here's another one. There's the Zoll AED. What's nice about these Zoll AEDs, the one in the lower left-hand part of the screen there, actually takes simple batteries that you can purchase. It's 10 batteries. They look like C-cell batteries, but they're a little bit bigger than a C-cell, a little bit smaller than a D-cell, and you can just purchase them and put them in the back. This is an AED also from Zoll as well. You can purchase an AED with leads involved, so you could attach 3 wires onto a patient and actually get a simple EKG. Some of the AEDs as well will change from an adult to a pediatric setting. In the world of using AEDs, when a patient is over 25 kilos or 55 pounds, it would be prudent to use the adult pads because that would give you a larger amount of energy to defibrillate the heart there. When a patient is under 25 kilos or 55 pounds, it is prudent to use the pediatric pads. The difference is the pediatric pads, even though they're smaller, they also deliver a small amount of energy, around 50 joules, compared to adult pads that may be somewhere around 150 to 200 joules. Some of the Zoll AEDs have a button that you can change from adult to pediatric in one push, as well as changing languages too. Here's another type of AED. So here's one of our first aid kits that we sell on my website at www.4americansafety.com. So this is the ASI 13. Similar products inside, has a few more bandages, but it has the same pocket mask as well as the tourniquet. Do you have a medical kit? So we've teamed up with Health First Stat medical kits. I've looked at all kinds of medical kits. When I go into medical offices and I look at their kits, I'll see several different types of epinephrine, several different types of Narcan, and it seems like they're sold too many medications in these kits. Health First has a really nice kit. They sell you exactly what you need, and they can also refurbish your medications when needed. So some of the medications that we recommend that you put in your first aid kit, of course, is aspirin. Some of the first aid kits I've seen will have a simple aspirin tablet, 325 milligrams. The downfall of this is when we're giving aspirin to a patient with chest pain and they're chewing up that aspirin, it's going to be really hard for them to chew that up. The 81 milligram children's chewables are more prudent in that they're easy to chew, they're tear-coated, and it's just a lot nicer for the patient. This is a very important medication when we're giving our patients having a heart attack, or as we call it, an acute coronary syndrome. Diphenhydramine hydrochloride. Some people call this Benadryl. So we've got the chemical name and we have the trade name. If you're going to be using a generic diphenhydramine hydrochloride or a generic Benadryl, make sure it does have that active ingredient, because it is diphenhydramine hydrochloride that actually causes that antagonist in case somebody's having an allergic reaction. Should you use liquid or pills? We found that patients that have a simple allergic reaction and then someone gives them a Benadryl pill, it's a little bit harder for them to swallow, especially when they're going from that allergic reaction to a full-blown anaphylactic shock, and that airway is going to close up. So for that reason, we feel it's prudent to have the liquid Benadryl. Though it is a pediatric dose in that cup, 25 milligrams, you would just double the dose for adults. So adults get 50 milligrams of Benadryl, and a child under 30 kilos would get just 25 milligrams. Epinephrine. Epinephrine for anaphylactic shock. Injectable, intranasal, comes in vials, comes in syringes. I'm going to show you some of the applications with epinephrine coming up in some slides. It's very, very important to have epinephrine, and even some states it's required for you to have that epinephrine. Though you need to know it comes in 2 different doses, 0.15 milligrams of epinephrine for a patient under 30 kilos, and when a patient's above 30 kilos, it's 0.30. You can get that with these different applicators, the syringes, the injectors, or the intranasal medications. Narcan, narcotic counter, comes in 2 different doses. A simple spray in the nostril, 4 milligrams, or you can get it as an injectable, or you can even get it as a vial and inject that into the nose. Some of the benefits of having the smaller dose, the 2 milligrams from the vial, is that you can titrate this drug. We feel that some patients are having an opioid overdose, not because they're doing heroin, but because they have too many fentanyl patches attached to their chest. The first step in any medical emergency that has to do with an opioid overdose is maintaining that airway. We recommend that you maintain that airway, start bagging the patient if need be. Your patient could be 45 years old, breathing 4 times a minute with a pulse ox of 66. You'd want to open up that airway, start bagging that patient, 1 ventilation every 5 to 6 seconds, and then start using the antidote. If you're using the simple nasal injector that you would get free at any hospital or fire station or police department, you have to give 4 milligrams in that nostril. The downfall of that is if you do have a patient with a narcotic patch on their chest and you give the 4 milligrams, you may block all the opioids that they're getting, and now they're back in pain again. So sometimes I like to titrate my Narcan, sometimes I need to give the full dose in the nasal. So they're both good applications, but they have different purposes, of course. Some of them have the meter dose inhaler. Sugar. Should you just have some orange juice in your office? Do you need the glucose tabs or the glucose paste? How do you give that glucose anyway? So in the glucose 15 grams of glucose, that would actually go in the buccal route. You'd want to apply that to the patient's gums. Sometimes just doing sugar. So what you got to say to yourself is, what sort of diabetic medical emergency am I having? Is the person hyperglycemic or hypoglycemic? It may behoove you to have a simple bedside glucometer. The industry standard or the national guidelines state that a patient from 60 to 120 milligrams per deciliter has a normal bedside glucose, and that a patient that has anything less than 60, hypoglycemic, that is a true medical emergency and that we need to administer sugar. On the flip side of that, it could be a patient with a high bedside glucose greater than 120 milligrams per deciliter. In this case, we'd be looking for a patient to have some sort of antagonist on them to help that. Here's a couple of EpiPens that are out on the market right now. So our first one is it's called the EpiPen. That's actually a brand name. The EpiPen is a brand name, and it has 0.15 milligrams of epinephrine for the pediatric one, which is green, and then 0.30 milligrams of epinephrine for the adult one. And this depends on if the patient is under or over 30 kilos. Of course, an easy way to remember this is just think about the bananas. Is when you buy bananas and they're green and they're new, all the new bananas, the green bananas, get the green EpiPen. When bananas get a little bit older, they turn yellow, and they would use the yellow EpiPen. Some of the other EpiPens that you can get with your medical kits from Health First are these. These are called the AviQ. The benefit of the AviQ is it has the similar doses, the 0.15 and 0.30, but these things talk to you. So if you've got personnel in your office using these and they don't know how to use them, the AviQ is going to be your best bet, because once you pull the cap off of it, it's going to start talking to you, and it's going to walk the provider all the way through this. In a medical emergency, it is life-threatening, and giving that epinephrine, it's very, very important that you give that. And then this is an example of the adult AviQ. The first one was the 0.15 milligrams of epinephrine, and that was the pediatric one under 30 kilos. And then this one is the 0.30 milligrams of epinephrine, and this is the adult one. Here's the new one that's out on the market. It's put out by a company called Neffy. It's FDA approved. Some states still don't have this authorized or approved. This is a simple in-the-nose injectable But you have to look at this. This is only for patients over 4 years and up and over 33 pounds. Let's talk about some of the medical kits that you can get with Health First. So this is one of the more basic kits. As you can see, it comes with the epinephrine and some vials as well as nitroglycerin. When you look down here with the nitroglycerin, this is a nitroglycerin spray. Some of the sprays are pretty easy because you just spray them and they go in. You can also get them with nitroglycerin in pill form. The difference is that when we have a patient with an acute coronary syndrome and we're giving the pills, sometimes the mouth is dry and the pill doesn't dissolve. So you have to think, all right, do I need to help this patient wet their palate prior to giving that nitroglycerin tablet? 0.4 milligrams, by the way. And then you can see it has the glucose 15, it has the epi injectors, it has the Narcan, and it also has a metered dose inhaler for your airway, your simple airway emergencies. Here's another one that you can get as well. This one's in a hard kit, kind of like the first aid kits, the ASI 12 and the ASI 13 respectively. On the ASI 13 first aid kit comes with a hard box, depends on your application. Same thing with these med kits as well. This is a hard box, has a few more extra medications in there. Again, it depends on your application and what you're using it for. Let's talk about education in your office. So I found that a lot of people have a misconception about what sort of training should go on in your office. Here's some basic education tips for you as well. So one of the most important things that we're going to learn in the office is CPR, or basic life support. Everybody in your office should learn CPR. ACLS, that depends on if you have ALS providers, you have an ALS kit, and you're doing ALS procedures inside the office. Anybody that does sedations or surgeries or anything like that, of course, is going to have an advanced cardiac life support course. It's very, very important that just the ALS providers take this course. Though everybody can take the course, but it's the ALS providers that are required. I'm going to talk more about that in a little bit. PALS, Pediatric Advanced Life Support. So in the fire department, we have what's called a length-based resuscitation tape. That's from 0 all the way up to 36 kilos, about an 8-year-old child. So in the medical field, or in the emergency medical field, anybody under the age of 8 is considered a pediatric patient, and we would need PALS, Pediatric Advanced Life Support. The misconception is that everybody in the office needs a PALS course. You may have providers that are LVNs or CNAs or any medical assistants that are out there, and they don't necessarily need PALS. In fact, PALS is really just for advanced providers, but PAIRS is actually going to be a better course. I'm going to talk more about that in just a second. Advanced first aid is depending on what your situation is. Do you have a specific situation? Some of the clinics I've been in, they're dealing in different types of blood, and they needed specific first aid procedures and dealing with that blood. How about an active shooter? Are you in an environment where you could have an active shooter or a bad character? So we do a lot of training out there for active shooting and tactical things as well. I'm going to give you some tips, and it's going to help you stay alive in case of an active shooter. We also do a class called Tactical Combat Casualty Care. And of course, that's going to be for a medical facility that's behind enemy lines. Let's say that you're working in a medical facility for General Atomics or one of the companies that may work overseas. Qualifications: BLS, Basic Life Support, and Heart Saver. Two different types of CPR. When we go out there and train the community, we do something called Heart Saver. Heart Saver is a class that we may do for a church, or for some police officers, or for some physical fitness coaches or football coaches. That's called Heart Saver. They don't have to check pulses. They learn basic CPR. Sometimes we'll add pediatric CPR as well. But when you have basic life support, That's talking about medical people. Anybody that calls somebody a patient needs the basic life support course. This is going to be 1 and 2 rescuer CPR. We're teaching pulse checks. We're teaching bag valve masks. We're teaching pocket masks. We're also checking with AEDs, using AEDs, and advanced care as well. So you need to know what sort of course you're getting, and do you have the right certificate, and are you getting the right training? ACLS with your AED. So when I'm teaching ACLS classes and I go into a clinic, they may not have a monitor that cardioverts and defibrillates, like a Zoll monitor, like a LifePak 10 or LifePak 15 that we might find in the emergency department. If you're an ACLS provider and you have an AED, you can do some of the first initial steps of ACLS with an AED. First thing you want to do is make sure that all patients in cardiac arrest are going to get epinephrine. So that's easy. You don't need an AED to tell you the patient's in cardiac arrest. A simple pulse check of 5 to 10 seconds is going to tell you that that patient is in cardiac arrest and needs that first dose of epinephrine. So now that you've started CPR, you've called 911, we've attached the AED, and it analyzes. Typical AED is going to analyze about 3 times, 2.6 seconds. It's going to look for an arrhythmia or dysrhythmia. So if you think about it, an AED doesn't tell you if a patient's in PEA or Torsades-de-Pont. It's only going to tell you if the patient's shockable. It's a very simple algorithm. So if you attach an AED and it says analyzing and the patient is not in a shockable rhythm, they're in cardiac arrest for sure, but they may be in PEA or asystole. In this case, continue CPR, continue to give epinephrine every 3 to 5 minutes, and run down your H's and T's: hypovolemia, hypoxemia, hydrodosis, hyperthermia, tablets, trauma, tension pneumothorax, cardiac tamponade. If your AED says that a shock is advised, then we know the patient is probably in ventricular fibrillation or ventricular tachycardia. In that case, they would need an antiarrhythmic, as we call it, a sodium channel blocker. All ventricular arrhythmias need a sodium channel blocker. I call it Victoria's Secrets. All ventricular dysrhythmias need a sodium channel blocker. For example, lidocaine or amiodarone would be some of the more common drugs that we give a patient. So your AED says shock advised. Now what we're going to do is go back and forth between the epinephrine and the sodium channel blocker. 1 milligram of epinephrine followed by 2 minutes of CPR, followed by analyzing the AED, deliver a shock, and then give your first dose of your antiarrhythmic. Another round of CPR, 2 minutes. AED analyzes, delivers a shock, give your next dose of epinephrine, and so on and so forth. PALS versus PAIRS. So pediatric advanced life support. In this course, we teach the ALS providers how to administer medications. How do you draw up 0.01 milligrams of epinephrine for a patient that is 20 kilograms? How much sodium bicarb do you give that patient, 1 milliequivalent per kilogram? So in the PALS course, we teach people how to use what's called the length-based resuscitation tape, drug doses, advanced airways, and the more common shocks: hypovolemic shock, distributive shock, cardiogenic shock, and anaphylactic shock. The other course is called Pediatric Emergencies, Assessment, Recognition, and Stabilization. These are for non-ALS providers. This could be for a CNA or an LVN or somebody that's going to assist an ALS provider. The beauty of these courses is they can be taught together in the same classroom or in the same office with the same ALS and BLS providers. We recommend that, in fact. In fact, when I'm doing a PALS class and there's some CNAs or LVNs or somebody that's going to be assisting the ALS provider, I want them in that course so that they know what the ALS provider is doing, as well as the ALS provider would know what the BLS provider is doing. In the PAIRS program will teach high quality CPR, the use of AEDs, ventilating with the bag-off mask, and how to assist the ALS provider. Run, hide, or fight. Everybody's got this on the back of their mind now. We live in a world that just has some bad actors in there. You could be in the nicest place in the city and one bad actor can change it right away. So there's a program called Run, Hide, or Fight. It's just that simple. Are you going to run? Are you going to hide? Or are you going to fight? The fire extinguisher is a great tool to have in your office. People will have fire extinguishers for obvious reasons, depending on the type of fire that you may have in your office. But did you know that you could use the fire extinguisher in this program, the Run, Hide, or Fight? Some of the simple steps are, grab the fire extinguisher is the first thing you're going to do, and run to a safe area. Do you have this safe area already? Do you have a back room? Does it have a lock? Is this where everybody's going to go? Does everybody in your office know this is the location they're going to run to if there's a bad actor coming through the front door? So now you've got your staff and you in the back room. You've got the door locked, the lights are out, the cell phones are off, and you have your fire extinguisher in your hand. Cell volume, it has to be off. The experts have proven that when there's bad actors outside that door, if they hear a cell phone go off, it infuriates them. They want to get in that door and get that person with that cell phone. Make sure that everybody knows that if you're hiding from a bad actor, that their cell phones need to be off. Pull, point, and squeeze. So now that we've got our fire extinguisher and we're inside this door, that's no proof that this bad actor is not going to break the door down and gain entry in there. But you're ready for this person. You've got your fire extinguisher with carbon dioxide. You've got the pin pulled. You've got the handle ready to squeeze, and the cone is right in this person's face. When this person makes entry into this room, you're going to pull that trigger and discharge the entire amount of carbon dioxide in this person's face. That's going to buy you about 30 seconds. And then after you do that, then you're going to hit this person on the head, depending on what you can do. But you would want to hit them on the head, and then that's when you're going to make your escape. The other thing is, after you run, you may need to run, but where are you going to run to? Does everybody in your office know where you're going to evacuate? Heck, it could be something like an earthquake or a fire. That's not when you're going to be hiding in the back room. That's when you're going to run down the stairs and out the front. Do you have a safe area outside your office for everybody in your office to go to? Does everybody know where it is so that you can make an accounting of everybody that's in there? So if you're inside the back room and you need to make your way out of there, your only egress may be a window. Again, I'm going to go back to the fire extinguisher. We can use that fire extinguisher to break that window and then get access outside. Where are you going to meet? We've made this in-office emergency instruction sheet for you. If you go to our website, www.4americansafety.com, click on the Office Emergencies button, and you can download one of these emergency instructions and then laminate it and show that to everybody. Some of the information that's in the instruction is how to deal with heart attacks. As mentioned, we call this an acute coronary syndrome. Also, cardiac arrest, starting chest compression, CPR, 30 to 2, 15 to 2. How about an allergic reaction? Are we going to be using Benadryl? Does it have diphenhydramine, hydrochloride? And then the patient goes into a full-blown anaphylactic shock. Who's going to be using the epinephrine? Is it the vial of epinephrine that you need the 1 cc syringe? Or is it going to be somebody that just uses an EpiPen? Or do you have one of those Neffy intranasal inhalers? How about those diabetic emergencies? Do you have that bedside glucometer? Is the battery good? Do you have the test strips all ready to go? Remember, 60 to 120 milligrams per deciliter. Got to be ready for those diabetic emergencies. And then finally, the airway emergencies. From a simple airway emergency where we can be ventilating the patient to chronic obstructive pulmonary disease to a patient with asthma. Do you have a metered dose inhaler? And does it have a tube on there that your patient can inhale with it? Is it albuterol or is it Atrovent? As I mentioned, if you go to our website, you can download this. I recommend that you laminate it and keep it in your office in an area where everybody knows where it is. Well, finally, thank you for joining us in this video. We hope that it was helpful, and I hope that you don't need this video, but if you do, hopefully that it helps you. Again, if you go to our website, www.4americansafety.com, and click on the All Medical Offices tab, and there you'll find first aid kits, AEDs, and a link to get your medications. Also, our website, you can reach out and talk to us as well. If you have any questions about your office or something specific that we can help you with, please reach out to us and call and let us know. We will be more than glad to help you. Thanks again, and again, my name is John Klatt.